All right, welcome back. In this audio lecture, we're going to be learning about another alteration in ventilation, and that is asthma. So hopefully, I think we're all fairly familiar with asthma, but here is a detailed description of what asthma is. And asthma is a periodic, intermittent obstruction of the airway, and what we get is we get swelling of the essentially bronchioles. Okay. Um, and so the swelling of bronchioles is triggered so in inhalation of pollution and then allergens can cause this asthma event. Okay, so you get this vascular smooth muscle contraction, or sorry, you get airway bronchial constriction, and so what we did is we get a diameter of the airways that is decreasing, right? Along with that decreasing diameter, we also have excess mucus production, right? And so we get swelling, we get smooth muscle contraction, we get mucus production. This all decreases the respiratory surface diameter. This is common in children. It is decreasing with incidence in adults. However, it is still frequent in some adults. Okay. We see it increasing in incidence in our population, okay, due to increasing pollution levels, and also due to this other idea of the hygiene hypothesis. So the hygiene hypothesis states that we're really protecting our children too much from germs, and so we need to expose them a little bit more frequently to some of these germs. So germs are a good thing. They help you build up your body into an immune system, and so if you are constantly keeping your children in a bubble, it reduces their exposure to these pathogens. And that's not saying we want to expose our children to diphtheria, but we do want to expose them to a nice rapport of germs, right? So not protecting them too much so that their immune systems are developing and they don't generate this hypersensitivity later on. Okay. So it's more common in adult women and young boys, and so we see kind of that flip. So men is not very common, and little girls is not very common. However, we can see as maturation occurs in boys, it kind of goes away, this hypersensitivity, and then women, girls, it increases in sensitivity as women age. So some risk factors for asthma include lower socioeconomic status because you would be exposed to those pollutants maybe more frequently. Generally, the condition of your homes is a little bit lessened. That's not because of anything that the parents are doing, but because of where those are located and the condition that those are maintained in. Generally, lower socioeconomic status is associated with renting. Usually, landlords aren't the most they don't care for their properties as well, so they can develop other issues. Okay. Obesity, this kind of goes with lower socioeconomic status, and that we have obesity associated with poor diets and poor lifestyle choices. Smoke exposure can cause this asthma, so any kind of real smoke exposure can trigger this asthmatic response. A familial history, so if it runs in your family, it's more likely that you will have it, and then race is going to factor into asthma as well. A little bit more about asthma. We see that you get this acute airway inflammation, right? So you get this inflammation event, what results in bronchoconstriction. So here we have a normal airway, here we have an asthmatic airway, and you see that the airway has gotten much smaller, right? So we could get bronchoconstriction, and we could get bronchospasm. And bronchospasm is similar to what we see in blood vessels when they spasm, so vasospasm. You get this periodic spasming, okay, due to activation of the autonomic nervous system, and specifically the parasympathetic nervous system would be responsible for constricting airways. And in addition to this bronchoconstriction and bronchospasm that are going to reduce the airways, reduce the diameter of the airways, we also have bronchial edema and mucus production. So this bronchial edema is going to result from increasing capillary permeability and increase exudate in that bronchial. Right? So if we get increased edema, this is going to result in swelling. Okay. We're going to end up producing more mucus, and so we get this hypermucus production. So we normally have mucus in there. However, during this asthmatic event, we are going to have an increased amount of mucus presence. Okay. This asthma can be classified a number of ways. most of the time it is classified according to the cause, and so we have various causes of this asthma. So we have extrinsic asthma. Extrinsic asthma is IgE mediated, so this is similar to a type 1 hypersensitivity. And what we see is we see mast cells are destroyed in the IgE mediated asthma that we see. Okay. Mast cells contain histamine, and histamine, when it's released, induces vasodilation and increased capillary permeability, and it also causes bronchoconstriction, so narrowing of the airways. So here are those reasons right here. We see that the histamine mediator increases the bronchoconstriction, increases capillary permeability, and increases mucus production. Right. So all three things that decrease the diameter of our airway and increase resistance to airflow. This generally presents during childhood or adolescence, and generally it is triggered by allergenic properties, right? So food, pollen, dust, and some medications. So anytime we have this respiratory inflammatory events, we have just generalized extrinsic asthma. All right, so intrinsic asthma. This is not an allergic reaction. It occurs after the age of 35, okay? And it is triggered by upper respiratory tract infections, air pollution, emotional stress, smoke, exercise, cold exposure. So we see that these triggers here will cause the intrinsic asthma because it's not coming from the outside. The air pollution is, but it's reacting with the internal, our internal system more. This respiratory infection is allowing a bacterial infection or a viral infection to build up in our system. Okay. Exercise and cold exposure are nice examples of this intrinsic asthma. All right, now we have nocturnal asthma. And so nocturnal asthma occurs between 3 and 7 a.m. and is generally thought to occur with circadian rhythms. So we see certain hormones are secreted on a circadian rhythm. So specifically cortisol and epinephrine, right? So we see cortisol and epinephrine levels decrease. Epinephrine is responsible for bronchodilation, right? And cortisol is responsible for bronchodilation as well. And at nighttime, as those levels are dropping, because these are stress hormones, we are decreasing the level of our stress hormone, and it picks up back up around 5 to 7 a.m. And so as these levels drop, we might not have been feeding on the bronchioles, resulting in bronchoconstriction. They also inhibit histamine. So histamine is what is primarily responsible for this bronchoconstriction. And without the cortisol present or the epinephrine present, we see histamine take an overriding role in this function. All right. So the next type is exercise-induced asthma. Then exercise-induced asthma usually occurs 10 to 15 minutes after exercise has occurred, and it remains for up to an hour after activity. Right? And we see that when you exercise, you're breathing more, you're moving out more air, and so this causes the airways to cool. And so this is actually a mechanism, this is a protective mechanism for your pulmonary system to warm and moisten the airways. So we saw in the intrinsic asthma that cold exposure resulted in this asthmatic response, right? But here we see it's really starting from a different source. So we see that this is generally followed by a refractory period that begins within 90 minutes. Within 90 minutes, it can last up to 90 minutes. So some athletes actually use this as a part of their exercise routine to make sure that they don't get an event later on within the event that they're actually taking part of. So they might induce an exercise-induced asthmatic response to protect themselves later on, because then they have a refractory period that can occur shortly after and can last 90 minutes up until the activity, after the activity. All right, so on this next type, we have occupational asthma, and occupational asthma sounds just like what it is. You get inhalation of substances at work, right? So painters wear paint masks. People who work with wood and sanding wood wear these masks too. it prevents the particulate matter from moving into the respiratory system. Now, there are accidents. These things are not 100%, and so we get some chemicals moving up into our respiratory system. So some examples of this can be plastic work or formaldehyde. Formaldehyde is a fixative that links sulfide bonds, and inhaling it can trigger this occupational asthmatic response. Symptoms develop over time. They don't happen all at once. It's increased exposure leads to an increased response. And we see that when the individuals take a break from work, maybe they take a step back and they take a weekend or they take a vacation, we see that the asthma can go away. So they don't get worse, or they don't stay consistent when you're away. They end up getting better because you're not exposed to the chemicals. All right, so next up we have drug-induced asthma. This is commonly caused by aspirin. Right? So prostaglandins are a part of the inflammatory response, and usually we take aspirin when we don't want the swelling or we don't want pain to be around, and so we will prevent the formation of these prostaglandins. Well, that ends up stimulating the formation of leukotrienes. Leukotrienes are formed through a very similar process, but is another arm which we can go down. And the leukotrienes, in turn, will be a bronchoconstrictor, and very similar to what we see with this inflammatory response with aspirin. And aspirin inhibits that response. Okay. So this can be a very fatal reaction if the bronchoconstriction is so severe that we can't get any air into our airways. Okay. This can be delayed, so it doesn't happen right away. This takes time to metabolize aspirin, from aspirin to end up inhibiting the COX enzyme that is responsible for conversion of arachidonic acid into prostaglandins. So the stages of an asthma attack. So stage 1. This is going to be related to bronchospasms. It's usually indicated when you start coughing. It starts peaking within 15 to 30 minutes of the actual reaction starting. This includes multiple inflammatory mediators, including leukotrienes, histamines, and interleukins. And so these are all inflammatory mediators, right? And inflammatory mediators are going to induce this reduction in the bronchial pathways to make it more difficult to move air in and out of the lungs. Stage 2 of the asthma attack, this peaks within 6 hours. Okay. It results in edema and mucus production, probably from those inflammatory mediators that were produced initially, so the leukotrienes, the histamine, right? So we see that these inflammatory mediators can induce the stage 2 reaction and increase mucus production, because that mucus is really a protective function, but now we're getting excessive production. And then the edema, it results in increased fluid being in an area and results in swelling of our tissues. So what can happen is you can actually end up trapping air in your lungs, and we'll talk about, when we talk about obstructive disorders, we'll talk about emphysema, and so this can actually result in air trapping as well. We'll talk about that, but the alveolar, as you take bigger and bigger breaths to try to get some air, you end up hyperinflating your alveoli, trapping that air inside. And so we're going to actually refer to this again when we get to emphysema, because that is largely what happens in emphysema. So in the stage 2, we see continued narrowing of the airways, and so the bronchospasm continues, smooth muscle contraction continues. Remember that the smooth muscle contraction and this bronchospasm are going to be the result of parasympathetic innervation, or the bronchospasm is going to be uncontrolled autonomic nervous system reaction. So we see inflammation continue to increase, right? So right here we saw the inflammatory mediators causing the edema and mucus production. Here we're going to see that they're still causing this inflammation. Now, the big thing here is that it's not just bronchoconstriction, it's not just mucus production, but it is a combination of the two that reduces the airways, that narrows the airways and results in increased resistance to airflow. All right. So what are you going to see when you have an asthma attack? Wheezing, right? And so as you push air in and out of these narrow passageways, you end up hearing wheezing. shortness of breath because you can't take a deep breath, labored breathing, right? So dyspnea as a result, right? So anytime you have any kind of compromised respiratory function, you would expect these manifestations to occur. Chest tightness, because now we have the alveolar hyperinflammation. We have the alveolar hyperinflation. We have coughs to get that mucus out of our lungs. We might start breathing fast, and if you start breathing fast, we can generate some anxiety as a result. So anytime you have hypoxia, you're going to have anxiety being produced. All right, so status asthmaticus. Okay. This is a life-threatening condition, so this is a prolonged asthma attack. Okay. It does not respond to the usual treatment that we see here. And so this can actually really lead to respiratory alkalosis. And so since tachypnea, so this is a rapid breathing rate, so if we're breathing out shallow breaths, we are quickly getting rid of carbon dioxide, resulting in alkalosis, and then we could get respiratory failure occurring pretty quickly thereafter. So we'll get more into respiratory failure in a little bit. So look, in diagnosing asthma, we're going to be interested in history and physical examination, information that comes from those two aspects, but also looking at pulmonary function tests. So this is looking at things like what stage or what classification of asthma would this fall into: mild, mild intermittent, mild persistent, moderate persistent, or severe persistent. And really, pulmonary function tests and when these manifestations occur is going to help us diagnose that and severity of the asthma that we see. We see that peak expiratory flow, if it is normal, it is greater than 80% of normal. We see that it is pretty mild, but we can see it progress all the way up to less than 60%. And if it's less than 60% in peak expiratory flow, we're going to see that this is severe, and it falls probably into severe persistent or possibly even into moderate persistent. So, then we look at the variability of that, and if we get a variability, meaning it is occurring not very often, and so if it's less than 20%, then it's considered mild, and if it's greater than 30%, it can be considered severe in that process. So for more information regarding that, look at Table 5-5, and that's going to be helping you to diagnose the severity of the asthma that we see, because we know that it has varying degrees of the severity. Okay. Arterial blood gases, so we're going to experience changes or decreases in probably arterial blood oxygenation. So we're going to be looking for that. We may be increasing red blood cell count, so erythropoiesis, to compensate for the decreased exchange that is occurring. And so to determine this, we might undergo some challenge testing, so to look for exercise-induced asthma, or allergen testing to look at environmental causes for this asthma. Treatment. For pharmacological treatments, we're going to use bronchodilators, corticosteroids, beta-adrenergic agonists. Okay, so beta-adrenergic agonists would open up our airways. They prepare us for exercise, and they make sure that plenty of oxygen can get into our blood. Bronchodilators do the same things, and they work similarly to corticosteroids. Okay. We're going to use nebulizer treatments, and so nebulizer treatments will often include steroid medications that are aerosolized, and then we inhale through nebulizers. Leukotriene mediators are going to induce this anti-inflammatory action. Mast cell stabilizer. So one of the reasons that we see this inflammatory response is increased action of the mast cells. And so mast cells contain histamine, and if we get increased release of histamine, not only does this cause cardiovascular issues, but it can cause inflammatory issues in the pulmonary system as well. And anticholinergics, right? So anticholinergics are used to block the bronchospasms due to the parasympathetic nervous system. So remember that the parasympathetic nervous system really decreases gas exchange. Okay, so that is a rest and digest system, whereas the sympathetic nervous system that is mediated by beta adrenergic agonists are going to open up our airways, making sure that we can fully oxygenate our blood. Some additional treatment strategies, developing an asthma plan, such as this over here, right? So this would be important to have for a healthcare professional to have, right? And so you and your doctor, physician, will generate this plan, right? So here's the medications that you take, how much to take, when to take it. Okay. Using a flow meter to detect how flow in and out of your lungs is being altered. So look at peak expiratory flow or forced expiratory volume. Okay. And so these two measurements will allow you to gauge how strong it is, right? Over here we see the progression get a little bit worse, and so this might be indicated by wheezing or tightness of chest, and so we see it fits certain categories. In the peak flow, we see that it's getting worse, and it's reaching 50 to 79% of this peak flow. Again, refer to table 5-5 for more information about these things. And then really it's what we're going to do, right? So quick relief medication, keeping yourself in the green zone, and changing the medication accordingly. Right? This red zone is the most severe zone, and so here our peak flow is severely affected. We see it say less than 60% in the textbook, but in this table it really verifies this as less than 50% or 50% of the peak optimal flow. So we might use a beta agonist in this case or a corticosteroid to try to reduce the inflammatory events inside the bronchioles. So you don't memorize this, but be familiar with what this is and what it does and kind of what it is used for. Okay. Additional strategies for treatment: avoid the triggers. So if it's a high allergen day, stay inside, okay, or take precautionary measurements. Keeping your environment clean and avoiding fabric furniture where allergens can get embedded and can trigger this response. Okay. So we'll limit the environmental fabrics that you're exposed to, so couches and things like that. Filter indoor air. So sometimes additional air filters are required, or updating of your air filtration system in your house is required, right? So changing an air filter on a regular basis is a good way to reduce the allergens in the air. And then obviously, probably the most important one is maintaining a healthy immune system, right? Which is going to involve exercise, diet, and making sure that you are staying in tip-top shape. So with that, I want to end this lecture on asthma, which is a ventilatory disorder. It enables or inhibits your ability to deliver the gas to your alveolar exchange surfaces. And we have different types of this. We have different severities of this. And so make sure you're going in to how the various aspects of these asthmatic attacks. And until next time.